All right, folks. Hi, everyone. Thanks for joining. My name is Maurice BP Weeks. I'm the co-executive director here at Acre, and I am so pleased that folks have joined for what should be a really fun and super informative Instagram Live. So the title that we've given this next little while is Coronavirus, Racism, and the Failures of Medicine for Profit. So we obviously know that we're in the midst of a unprecedented crisis when it comes to the global pandemic that we're in. So earlier today, we surpassed 15 million people worldwide who've been diagnosed and tested confirmed with the coronavirus. Here in America, in the United States of America, we're spiking cases faster than we ever have before, with just today over 48,000 cases already, and it's only 3 p.m. on the West Coast. So we are spiraling out of control, and we also know that this is a virus that impacts people of color differently than it impacts white folks, for lots of different reasons that we'll talk about. And it's also part of the reason why we wanted to do this now, especially, and why the focus on race is so important right now, especially, is we're also at the moment of a real uprising for racial justice in this country. And we know here at Acre that if we're going to achieve any racial justice, it can't just be just justice about the police, even though that's extremely important. We know that black folks have been systematically targeted in many different areas, and healthcare is no different. So it's really important and timely to have this conversation right now. So a little bit about my background before I get to a much smarter and much more exciting speaker. So my background's in community organizing. I'm the co-founder here at Acre, and we've been around for coming on 4 years relatively soon. Our main focus is on holding corporations accountable and making sure that we're doing that with a deep focus and lens of racial justice. So we know that wealth extraction from people of color is the main way that corporations operate, and we don't want to hold them accountable in a race-blind way. We want to run campaigns that really challenge the nature of racial capitalism in this country. So that's a little bit about me and a little bit about the moment. We have a particular focus on big pharma right now, who, when you talk about wealth extraction of corporations from people of color, there really is no better example than the big pharmaceutical companies, who jack up their prices at any chance they get, literally any chance they get. They have patents to produce medications that really the public had their hands in actually doing the science behind. And these are all medications that few folks really need and really are life-saving and quality of life improving things that big pharma is really just trying to extract as much money out of as possible. So we're going to talk a little bit about that and many more things. I'm going to go ahead and add our speaker here. Waiting for her to join. And there she is. Hello. Can you hear me? I can't hear you. I can just barely hear you. Say something again. I think she might unjoin and join back again. Yep, I can hear you just barely now. Speak louder. Do you have a pair of headphones you could get? Go get a headset. So you can tell that obviously.
Right, there we go.
Oh, okay, perfect.
You're like the smarter one.
Okay. So obviously, both visually and by the way I'm talking to this person, you know that we are related. This is my sister, Lachelle. So, Lachelle, thank you so much for joining. And I want to start, this is really fun. I get to interview you.
Yeah, it's so weird.
We talk a lot about your work and my work, but we've never done anything like this before, obviously.
This is like a first. This is the
This is,
most public that I think anyone in our family has gone with
yes,
family interaction.
that's true.
We
That's
might
true.
explode.
Yes, yes. Who knows what will happen? Yeah. Let's start by, so it's my understanding that in the Hippocratic Oath it says do no harm. Why did you push me down a flight of stairs in a laundry basket years ago?
So that didn't happen against
It
your
did.
will.
Oh, okay, I see.
So
All
that was
right. So,
a joint decision, and you didn't almost die. You were fine.
well, that's, we'll let the public decide. Uh, all right. So, but seriously, thank you for doing this. And I want you to start by telling the folks who are on here a little bit about yourself um, and your education background, the kind of work that you do now. Just a little bit of an intro to you.
So I am an MD PhD, so I did a lot of school. Um, and I am a physician scientist as a result. So I do a combination of seeing patients and then do research about diseases that those patients have. My focus is in leukemia and particularly in the prevention of leukemias. Um, and so I think that answers your question.
Yeah, yeah. And I know you do a little bit of advocacy and writing in your work as well, and we'll get into that a little bit later. So I want to start by asking, you're in Boston. Boston is a major city, and like all major cities in the country, it's been hard hit by the coronavirus.
Yeah.
How has life as an MD been since the coronavirus hit the city?
Yeah. So it's been different. So it was probably around March when our hospitals in the area that I'm in, the Harvard hospital system, all started to sort of shut down. And not shut down like close their doors, but scale down operations that were non-essential. So elective surgeries, whether it's an elective plastic surgery or you need a tumor to be removed, they define elective as something that's not emergent. You don't have to have it right
Wow.
now. Those things were canceled or pushed back. My research lab was closed for a period of time. And then, I have an autoimmune disease, as you know, but people might not know. So I take immunosuppressant medication. So I was not in the hospital taking care of patients during Corona. During the surge, I was doing more virtual consults and doing like talking to patients over the phone, doing telemedicine visits, things like that. And so that was different. That was something completely new
Yeah.
that I'd never done before. And then, I will say for my colleagues who were in the hospital life was completely just, you could have worked as a radiologist for the last 5 years and you were called upon to be bedside taking care of people. It was
Wow.
the
Yeah.
surge of cases just required everybody to be very flexible in ways that we could argue about whether or not it's safe, how flexible people had to be, but people had to be a lot more flexible in terms of their role during.
And folks might not know, so like a radiologist, that is literally someone who just looks at images of
Yeah, like
scans.
people who went to med school and then chose a specialty where they did not have to touch people.
Yeah.
Yes.
That is what I would do if I have gone to med school for sure.
Yeah.
Um, so that's helpful context and sort of mirrors what a lot of other folks have said, physicians have said about the coronavirus.
Yeah, and even
I'm
now it's like
curious.
still very, very different. So like I'm back in the clinic
Yeah.
now, but we are wearing masks in the clinic. We are still kind of limiting our physical exam to things that are absolutely necessary. Patients aren't bringing family members in like they used to for visits. So I work in a leukemia clinic. So you can imagine that if you had leukemia, you would want to bring somebody with you to the visit.
Absolutely. Yeah. Yeah.
But you are like going by yourself. Patients are being roomed right away, which is a great thing. If anybody who's listening who's in medicine knows that like having patients roomed, or anybody who's been a patient knows that you sit in the waiting room usually for a very long time. But now patients are being put in the room kind of as soon as they arrive. Um,
Yeah.
but it's just it's a much more sterile environment, you know, where you would normally like hug a patient or shake their hand.
Right, right,
yeah.
Right. So Boston is obviously known for many, many things. But one of them that I know we talk about often is its, let's call it a complicated history with race and racism.
Yeah.
And I'm curious from your perspective what some of the ways the pandemic has either exacerbated some of the racial tensions and divisions inside of the city of Boston or made them less significant.
Yeah, so Boston is the most segregated city that I've ever lived in. Not that I've lived in a ton of places, but I lived in Newark and Cleveland, and I'm just used to seeing a better admixture of people. And, you know, one of the things that I did when I was a resident is I started this social justice committee so that residents could have an outlet to talk about different things that were going on in the hospital or not going on in the hospital. And one of the first conversations that I had with one of our execs at the hospital about the committee was, you know, I could leave my apartment in Brookline and walk to work and work for 12 hours in the cardiovascular ward, and the only Black people I see would be environmental services workers. Like I wouldn't hear a single patient who was Black. I would have no colleagues around me who were Black. It was actually possible to do that in a day. And if you think about where my hospital is, like we're right in the Mission Hill area, which is a historic area for Black people, really close to Roxbury, which is where, you know, all of the Black Panthers and everybody were, you know, and that area is still like 60, 70% Black. But our hospital, is particularly in the specialty services, doesn't see a lot of Black people. And so thinking about coronavirus, so I'm doing this research project right now where I'm looking at so one of the things that happens with coronavirus patients is that they tend to get blood clots just at a higher rate than normal. And so I'm looking at patients who are hospitalized with blood clots with coronavirus. And the first thing that I noticed when I was just putting together my demographic table was how many Black people are in my sample. Mm-hmm. It's like something like 30 or 40% Black, which is just not anything that I experienced as a resident of the hospital.
Right.
And so, you know, I think, you know, just like anywhere, coronavirus has unmasked a lot of the structural racism that's in all aspects of society, but certainly is in medicine. And medicine is sort of in the center of, you know, this economic racism and housing racism. All of these things sort of feed into the health of a nation. And so I think coronavirus was one of the lights to sort of shine on those issues.
Yeah, yeah. So I want to dig a little bit deeper here, and I'm going to read you a quote of yours from Health Affairs. I feel like mom right now. In talking about
yeah, somebody not knowing how to use Instagram.
The idea of getting our mother on Instagram, I just can't. Yeah. You're talking about a particular study on COVID-19, and it says, quote, overall, the study found compared with non-Hispanic white patients, African Americans had 2.7 times the odds of hospitalization after adjusting for a number of other demographic categories. Mm-hmm. In an initial version of the article published online, authors explored several possible explanations for the observed disparities. They noted that one hypothesis is that there may be some unknown or unmeasured genetic or biological factors that increase the severity of illness for African Americans. They then discussed additional societal factors that could have contributed to the disparity, including unconscious provider bias, patient distrust, and financial stress. Yeah. But this analytical framing ignores racism as the mechanism by which racial categorizations have biological consequences. Yeah. Can you say more about how this works in practice and just some of the ways that racism shows up in medicine? Yeah. And then what we can do about it at all three levels, like both the patient level, the doctor level, and the research side. Yeah.
So, you know, first I want to acknowledge my co-authors on that piece, Monica McLemore, Edwin Lindo, and Rhea Boyd. They allowed me to really be a part of something special with that. So I just want to make sure that I acknowledge them. And then the other thing that I will sort of start out by saying is that anytime we identify these sort of health disparities, you know, so like Black people non-Hispanic Black people are 5 times more likely to be hospitalized from coronavirus than non-Hispanic white people. Hispanic people are 4 times more likely to be hospitalized than non-Hispanic people. And so, you know, anytime we identify these sorts of disparities, the first thing that there's this like faction of the medical research community wants to do is say there must be some like genetic polymorphism or whatever that proves some biological link that proves why these Black people are flawed, right? And the issue with that logic is there are a lot of issues with it. But I think that we have sort of beaten that horse to death. You know, we had the entire Human Genome Project. We have, you know, Fatal Invention and Killing the Black Body, written by Dorothy Roberts. Like, we have all of this data and all of this information that basically tells us that race and biology are not synonymous in any way. There's no race gene. You know what I mean? There's no gene that codifies whether or not a society is going to say that you're Black or someone else is white. You have a melanin gene, the MCR1 gene encodes melanin, but we don't even categorize people racially based on how much melanin we perceive in their skin. Somebody who is Indian and somebody who is from China, they're both Asian. And somebody who's darker than me who lives in Egypt, that person, depending on what census form they fill out, is white and I'm Black. So it's a completely made up sociological construct that does not approximate biology in any way or fashion. And so I think that what we have to somehow get researchers to do is not jump to that, which is a holdover from slavery. It's a holdover from trying to justify doing experiments on Black people without their consent, doing experiments on people to figure out, you know, what is the root of the less human nature of Blackness so that you could justify enslaving people. That's why we have that race and biology link in the first place, and it's just made up. It's made up to keep people oppressed.
Yeah, it's interesting thinking about the history of that, because I mean, I feel like when we study different eras of racism in America, we see that pop up often where, well, of course Black children can't learn this thing. It's because they're Black. They don't have the capacity to do this.
Exactly.
And it seems like the type of thing that I think anyone would obviously say is medically debunked. So it's very unnerving, let's say, to think of researchers still using that in 2020.
Yeah, I mean, one of the papers, and I forget who the first author on this paper is, but it was a science paper published a few years ago, that basically the authors took DNA from an Asian person and from 2 white people, 2 people who identified as white. And the Asian person was more similar to one of the white people than the 2 white people were similar to each other.
Right.
And so it's just ridiculous to me that would be the first thing you would think of when you see a disproportionate or a disparity between Black and white, that you would think, oh, there must be some racial thing that's going on that's making these Black people sick. And it's without thinking about the history of our country in any other way, thinking about how redlining has controlled who ends up in what housing areas, and therefore controls what hospitals you have access to and what schools you have access to, and therefore what jobs you get, and because jobs are linked to insurance in our country, for whatever reason, what insurance you have, which determines what healthcare you get. You know what I mean? It's all linked in this way that is so clearly connected to structural racism. So to not name that and to name some made up biological thing is non-scientific and just stupid. Yeah. I remember one of the flags that I really appreciate you giving me before was, you know, that when you do blood work for all of the Black people who are watching, there will be several different categories on your blood work that there will be a regular range, and then your doctor will have a Black range. So like
Oh yeah, like
Yeah,
you like of course your range on this is lower. It's because of black people, and to actually challenge that
yeah,
and think about like the fact that something might actually be off
yeah.
because of what you're saying. This is totally outrageous.
Yeah,
Is just a
yeah,
really
no,
helpful
I
thing
think
to have.
the medical community, at least like in the Mass General Brigham area, recently they made the change to stop using the racial correction for GFR, which is a measure of your kidney function. So it used to be there was this really flawed study that was done that basically suggested that Black people, because they have more muscle mass, have a higher a higher creatinine and therefore have higher number, you know, kidney function numbers are going to be a little bit different than white people. So there's a correction that we have used in medicine for a long time. And hospitals just now are starting to take that correction away because it doesn't make sense to say that because somebody is categorized socially as being Black, their muscle mass is a certain way. Why don't you just measure their muscle mass?
That's a good
Dorothy Roberts
good
did a
question.
TED talk on this that was excellent, that really went into explaining it. And like in her books and her writing, explain this very well, that this is just ridiculous. It's not science.
Yeah, yeah. Well, I want to switch gears a little bit and talk about pharmaceutical companies because I know obviously that's I mean, you know, that's a huge part of what I work on
Yeah.
when it comes to health. And I know that it's something that you think about a lot too. So um, for those who might not know, there might be some people in the audience who are coming at pharmaceutical companies in the way that I do, where they're just
Mm-hmm.
like, they kind of hate capitalism.
Yeah.
Pharmaceutical companies make a ton of money, so they
Yeah.
hate pharmaceutical companies.
Yeah.
Can you talk a little bit about like how pharmaceutical companies actually interact with doctors and physicians?
Yeah. So pharmaceutical companies and academic medical centers work together in a lot of ways. Um, and one of the major ways is in sort of coming up with taking a concept from somebody's brain and putting it into and getting it into something that someone can inject or take by mouth as a medication. That requires a lot of time. Like you're talking like 10 to 15 years for development. And you're also talking about millions upon millions upon millions of dollars. And so for an academician who's getting their money from a combination of institutional funds, philanthropy, and like National Institutes of Health funds, so government funding, it's just not enough to do that entire development process yourself. And so a lot of times, or most of the time, what'll happen, and what happened in the case of the most recent coronavirus vaccine that was just published, some of the preliminary results out of the NIH. They teamed up with Moderna, who actually has the capital to push
Right.
that vaccine forward. So in that way, I mean, I think pharmaceutical companies are a big part of what you do in terms of drug, or who you work with in terms of drug development. Just because you need capital, the way we've set our system up, in order to actually do the clinical trials, to do the pharmacokinetic testing, to scale things up, to scale things down, to do the marketing, to actually get drugs in front of people. You need
Right.
capital to actually do that.
Yeah. So I know one of the things that pharma sort of prides itself on is that they kind of describe it in a little bit of the opposite way even
Mm-hmm.
to what you have. So they describe themselves as the innovators.
Yeah.
That if it wasn't for Pfizer, if it wasn't for GlaxoSmithKline,
Yeah.
we would never have gotten the science behind how to make
Yeah.
Humira, how to make all of these medications.
So
It
there,
sounds like that might be
no, so
inaccurate.
I no, so it's not totally inaccurate. So there are huge research and development arms of pharmaceutical companies, and so somebody just out of graduate school with a PhD can go with their ideas and with their skills and ability, and go to a pharmaceutical company, and instead of working in an academic medical center in a research lab for some PI, they can work for this for-profit business and develop the same sorts of things. So the pharmaceutical
Yeah.
companies are like a think tank for information, and there are a lot of drugs that don't go through the academic medical center process, that just go through pharma. Um,
Mm-hmm.
and then pharma will then do some of their correlative scientific studies with the help of academicians. So that, kind of
Uh-huh.
works in both directions. I will say that like the major issue with the model that we've set up for how drugs actually make it from people's brains to actually helping someone's health is the whole idea that we are so heavily reliant on this for-profit infrastructure,
Right.
so a pharmaceutical company is interested at their bottom line in making money, right? And so if it costs millions and millions of dollars to develop a drug, they need to recoup that and make a profit so that they can develop the next thing. And so that's why you end up getting these exorbitant prices on medications, particularly medications that are only going to go to a very small population of people. You have to price them very high in order to recoup what you're getting. Like there was a medication I prescribed yesterday for a patient that is $20,000 a dose, and you're dosed every 2 weeks. And luckily she has great insurance, so it's going to cover. But like it was
Wow.
a
Wow.
$20,000 situation every 2 weeks.
Yeah. Yeah. That is totally outrageous.
Completely. Like no one can who can afford that, right?
Right.
Unless
Yeah.
you're Jeff
No. At
Bezos and
that
you
point,
just
it's
make
just
$50
silly.
billion off of the pandemic. You can't
Right.
afford
Right.
that.
Yeah. Exactly. Exactly. Um, Yeah, so Acre is getting ready to release a report soon that calls out some of these practices by big pharma that you talk about, and the flaws in the system of like how they do wealth extraction. So them taking in all of this money in profit, and one of the things that was underneath what you were saying, but just to bring it up, is that they, for most of these medications, they get a patent that locks in their exclusive rights to develop and sell the medication, so they truly can charge whatever they want in the spirit of recouping their prices. Of course, they make a tremendous profit while doing it.
Yeah.
In our report, when we started to dig into some of the literature, we saw that Black folks, especially because of all of the societal things that we were talking about, are skipping medications, splitting their medication doses, not taking them at all. And you can connect these things to higher death rates of the coronavirus. If someone is really not treating their
Mm-hmm.
heart disease, their diabetes, their something, if they also get the coronavirus, they're at like an increased risk.
Yeah.
Do you, like in your doctoring, do you see this connection between the flaws of the pharma model in that way and like literally people dying, literally people not
Yeah.
being able to live?
Yeah. I mean, I think that is, it's not just a pharma issue. It's like a larger
Yeah,
capitalism issue, right? So
yeah,
if you, and like the fact that it's Black people dying disproportionately is because
right.
capitalism operationalizes racism in order to maintain value differentials, right? So you need to keep a class of people who are poor if you are a capitalist, and if you define a class of people as Black and keep them subservient, and then you get a group of people who are also poor and white who are so invested in keeping their whiteness that they are going to be vehemently against any social service because they're really trying to keep these Black people down. And Jonathan Menzel talks about this in his book Dying of Whiteness. This whole
Yeah,
idea
yeah,
that
yeah.
like that
That's a
this
really good
whole
book. I didn't know that you'd read that book.
yeah, this whole idea that like you know the reason why how poor white people make themselves sicker by just believing so much in this myth of whiteness, of supremacy of whiteness. So I think it's not just pharmaceutical companies, although we can like rag on them all day. I think it's all of capitalism. It's insurance companies,
Yeah,
it's the medical complex, HMOs, all of it. Is at fault.
yeah, yeah. One of the things that we have been pushing for is like a move towards obviously, healthcare that is free for everybody
Mm-hmm.
because we are just a ridiculous country for not having that. But the other thing is public medicine and public medication. So like, I just think of when when Mom and I sat through your presentation about your blood thing that I don't understand. It sounded like there was public monies that you were applying for, and this probably has happened other times in your career or some of your colleagues' career.
Yeah.
Public money that you're applying for through the NIH or something like that to actually do the research. And one of the things I wonder is if we could with our magic wand scale that system up so graduate student just coming out with their PhD doesn't actually go to work for Pfizer, but they work for a public entity that is also developing these drugs that people need that can then provide them for free.
That's a really lovely utopian dream. I will say that just about every president has defunded the National Institutes of Health. So like the pay lines when I entered graduate school, I think it was something like 15% of R01, which is like the big grant that you get once you become like a big kid doctor. So like the pay line was like 15 to 20%. And now they're funding at like 8 or 9 or less, depending on which institute you go to. So it's just really hard to get those grants. And so and like, the whole thing is set up to push people into this for-profit sector, right? Because if you have somebody who, they are going through grad school, they might be making $20,000 a year, depending on their whatever grad school program they're in, right? And then they graduate. This is a time of your life where you like want to have a family, whatever. You definitely don't want to live with your parents anymore. And so, so now you need to make money. And like, academic institutions aren't offering you that much money. They're offering you, you're capped at a certain amount. And not only that, you're capped at a certain amount, and you also have to compete to continue making that amount by getting these very difficult to earn grants. I feel like if I were in that situation and didn't have the medicine thing to also fall back on, I probably would be like really considering going to work for pharma because it would be a sure pay.
There's no other, there's no other choice. Yeah. I mean, you obviously are a brainiac, so you got a PhD. But for people who didn't have a PhD and had to actually pay for their education as well, I mean, you add that on top of it.
Yeah, exactly.
And like, I just can't imagine it's the same thing with lawyers, where we hear lawyers come out, they go in thinking that they're going to work for some union and then come out and
they're like, no, I really
helping corporations sue corporations.
They're like, give me Bain Capital.
Right, exactly. Where is Mitt Romney? That's who I want to work for. Well, that's that
depressing.
It's depressing, and really is like, you said that like utopian vision, but really if we're going to be an equitable society, we pretty much have to push towards exactly that.
No, and I was talking about this with some people on Twitter the other day about how like the things that we need in society are not mysteries in any way, right? So people need health. And people need health that doesn't cost a lot of money. And you're not getting it by making a medication that's $20,000 that somebody needs to stay alive, right? The solution to that is to give people affordable, free healthcare. And if you do that across the board, everybody's health will improve, right? Even just people's health will improve, but the poorest people's health will also improve if you don't charge them an arm and a leg to get it. But I think it's really a will question of whether or not you are willing to let go of this for-profit system, because if you let go of it here, it makes it that much easier to let go of it in other places. You have to place. And we really do need to let go of it in other places as well. Yeah.
One of my favorite examples in this, I'm way off script now, is the medication for Hep C. I'm wondering if you could talk a little bit about, I think people might not know about the medication for Hep C, both the
Harvoni.
yeah. Yeah,
Yeah.
so I wonder if you could talk a little bit about that and how outrageous that case in particular is.
Yeah, so it's not really like one of my major areas of expertise, but it years ago there were a couple of antiviral medications that were identified that could cure hepatitis C in individuals. And those medications have, you would
So
think,
wait, so we have a cure for Hep C.
yes. So the thing that is really concerning about it is that this, I was probably was I in med school or earlier when this happened? It was a long time ago now that these drugs were identified, and there's still large communities that do not have access to these medications because they're so exorbitantly priced. And particularly when you start to think about, and one of the things that I'm sort of side project interested in is healthcare for individuals who are incarcerated. When you start thinking about that population, which is particularly high risk for having Hep C, particularly people who are incarcerated for long periods of time, they don't have, a lot of them don't have access to this medication at all. It's very
Right.
difficult to get a contracted healthcare system in a prison to agree to pay this price for this medication rather than just pay for supportive care, which is going to be cheaper in the short run. In the long run, it's actually much less expensive for people to not have Hep C.
Right. Yeah. Yeah.
But in the short run, it's a bigger upfront cost, and it's harder to get these sort of contracted for-profit healthcare systems in prison institutions to pay for them. So
Yeah, I just wanted to bring that up because I know that blew my mind when I heard it for the first time. And there are often stories in the news about Hep C outbreaks within the prison system, and I just want everyone who sees those stories to know that there is a cure for Hep C. We actually have a cure for this thing that science found out, and it's only for societal reasons that we can't actually cure all of the people who have it. Um, so I want to shift to back to the coronavirus a little bit. So I know you read a lot of this stuff, you know. So can you give us generally updates on the search for the coronavirus vaccine? I know you started to a little bit
yeah,
before,
so
and how you're feeling about it.
yeah, so there are a bunch of trials right now, or I would say like research efforts underway to identify coronavirus vaccines. The last I checked, there were over 160 efforts in some form of development. Most of them are like in the lab, and so not in people, but I think about 30 of them are actually studies that are going on in people in some capacity. The two trials that everybody's watching are the Oxford trial, which got up and going first, and that was out of the UK, and they have arms in Brazil as well as South Africa. And that study is a vaccine trial that just had some really good results in phase 2. So phase 2 is like an efficacy study, basically. So it means that you're showing that you have already shown that the drug is safe. Now you're just trying to show that it does what you think it's going to do. And so they have shown that the vaccine does invoke a antiviral response, so you get neutralizing antibodies. So neutralizing antibodies will inactivate a virus, basically. And so that's incredibly promising. That study, the preliminary data, I think, had something like 550 patients or something like that. So it was a good effort. And then the trial from the United States was the NIH trial that they partnered with Moderna Pharmaceuticals. And that's a mRNA vaccine. And that trial also had like 40 people or so, but the idea was very, very similar in that they were able to invoke an immune response in individuals that received this vaccine. And so then both of these studies now are moving into the phase 3 realm, and phase 3 is basically you have a signal that says this drug will probably work. And so what you do is like a randomized study where like some people get vaccine, some people get placebo, or some people get something else. And you ramp it up to a large enough number of people so that you can see a difference between the groups. and if there is a difference between how much antibody is produced or how long the antibodies are around for. I haven't actually read the phase 3 trial designs, but then those would be the studies that would, the drugs or the vaccines that would go into people.
Yeah.
Yeah.
I wonder if you're concerned about this. I know that the company Moderna has actually never brought a product to market before. Like they got a bunch. Did you know that?
Yeah.
Which seems just, I gotta say that seems a little outrageous to me we would.
I mean, it does and it doesn't, right? So I think if it were the same groups of people doing the same, like the studies over and over again, then I think you would say like, okay, guys, like this is your 50th time.
Yeah, you don't know what you're doing. Yeah,
stop wasting our money and our time. But it's really like the way that pharmaceutical companies go. They're like investment companies for research,
I
so
see.
it's
Yeah,
really like they're like betting on a thing, and then other people are operationalizing it. And so I don't know if you can necessarily generalize their failure in other areas to this. And then
that's
also
very
I would say
good to
that
hear.
the other thing about drug approvals is that there's a lot of bureaucracy involved that does not necessarily it's not necessarily scientific. So there have been drug studies that I've heard about at like national meetings and things like that looked amazing, and it's just like, wow, this is great, like you can prevent heart disease, that sounds wonderful. And then like the pharmaceutical company kills the drug because when they did their calculation of how many people they would have to sell the drug to in order to make a profit, it it wasn't enough people, to actually push towards the marketing phase. So they killed it. And that whole arm of people who were working on that drug were just no longer working anymore. Like that happens a lot too. And so I think there are a lot of different moving parts. So you'd have to kind of know the specifics about why the other drugs didn't go all the way to market.
Yeah. Well, obviously that's incredibly infuriating. So, that's ridiculous. But I won't worry about Moderna now. That makes a lot more sense. That it's not like obviously I think people are picturing like the same 15
like
scientists sitting in the room and being like, oh, I got it this time. This time I got it. It's not that.
Yeah, it's not
okay.
that. It's not that.
All right.
Yeah, and like I think the stakes are so high with the coronavirus vaccine that I think that people are really scrutinizing those data very well. I won't say that about other coronavirus data. There's been a lot of stuff that has come out that is just like, this would never be published if we weren't in a pandemic. That's for another session.
So I know that folks in particular, another thing that people are worried about, which I think is a more significant thing, is folks being able to actually access whatever vaccine gets produced because of what we were just saying. I mean, like we have a cure for Hep C and people can't access it, so we still have Hep C. So is that, I mean, just from like a medical public health perspective, how important is it for this pandemic that we actually make sure that people have broad access to this vaccine?
So I think in an ideal situation, right, you would set up vaccination clinics the way you did for polio for something like this, right? Like that would be the national response kind of thing that you would need. That will probably not happen unless there's
you don't think so?
Unless there's a changing of the guard.
You don't think he's going to do that, huh?
Yeah, it just doesn't seem like, just based on what I've seen so far,
it
doesn't seem likely. But I think it's really important that a vaccine be widely available. I think what does concern me, well, there are lots of things that concern me, is how the U.S. is sort of moving in terms of the market for vaccines. So the U.S. is kind of swooped in for the Oxford vaccine and bought up a whole bunch of it, right?
Yeah.
It has a range with Pfizer so that we can be like the first people to get it in the U.S., right? Which you can say like, oh yeah, I want people in the I live in the United States. I want people in the United States to get the vaccine first. And like, we're the epicenter of this thing now because of bad decision making. So we should get it first so that we can like save the rest of the world. But it's just not an equitable way to sort of go about things. The person or the country that has the most money can go in and buy it all up. And so say like in 6 months, we're no longer the epicenter, and like, I don't know, the Gambia is, or wherever, somewhere else,
Yeah.
right? Then we have all the vaccine and they have not, you know what I mean? It's just,
Yeah.
it's not a way that I think we should be playing in the sandbox together. The other thing that is troubling about like the rhetoric around vaccines is this whole idea that like, oh, Black people are getting coronavirus more, and so therefore they should be upfront for the coronavirus trials.
That was going to be one of my questions
like
to you.
the first people who get the vaccine or whatever. And like, while I believe in vaccines, I think people should get them. There's no reason anybody should get measles, mumps, or rubella because we've had a vaccine for those things for years, right? So I totally believe in them. And I think if we have a safe and effective vaccine for coronavirus, the death that I've heard of people having or have had my friends, family members die of is not a death that I want for anyone, right? So it's like a suffocating death alone, and you're like upside down with some nurse holding an iPad so your family can watch your last breaths. It's terrible. So like, if there's something that can prevent that, I say that everybody should go for it. But the thing that's dangerous about that rhetoric is like this idea that Black people no longer have the autonomy to say, I don't want to be a part of your experiment, or I'm making a choice to not vaccinate myself, when you allow that autonomy to other people. It's this like paternalism that happens in medicine where Black people aren't allowed to make their own choice because somehow it's perceived that our choices are not, that we don't make choices that are good enough for ourselves. And that is troublesome to me.
I feel like it also, the thing that's troublesome about it to me, in addition to that, is that just like, we actually don't have a very good track record with like doing experiments on Black folks. And I think that's one of the comments in the chat, is that, this country is home to the Tuskegee experiment, is home to
Harriet Washington's medical apartheid, and like the whole idea when people start talking about like Black people mistrust and all of this stuff, or and somebody in the comments mentioned like Indigenous people mistrust, like we are a country that's founded on slavery and also founded on the genocide of Indigenous people, right? That we then said, we want your land, so now you got to march across the country. Like, that is how we started. So like, there's no reason that anyone from either of those groups should be like, oh yeah, I empirically trust you with anything, right? You like
right. Yeah.
Right.
Yeah. That would be unreasonable.
It would be completely unreasonable. And I think that the solution to mistrust isn't telling people what they should do or being forceful about things. I think the solution to, what you do to reconcile mistrust is actually change the systems that caused it. And there's no offering of that. It's just an offering of like, hey, you guys are dying anyway, so why don't you take this vaccine? And when you come to somebody with that, like, I'm going to be suspicious of your vaccine. Like, why all of a sudden do you care about my health enough to give me a vaccine when you don't care about it enough to make sure I have adequate health insurance so that I can go across the street to the hospital?
That's right. Yeah.
It just like, yeah.
Yeah. Yeah. I think that's that makes a tremendous amount of sense. So we are almost at the top of the hour. I want to, so for this report that we're releasing, and you know how our organization and reports are very direct, let's say, in their criticism of, yes, their criticism of the capitalist class. So this report's title is also in that direct lineage. It's called Poison: How Big Pharma's racist listen to the subtitle, Lachelle.
It's really subtle, though. Really.
Poison:
really subtle.
How Big Pharma's racist price gouging kills Black people. So and we want it to be sort of attention grabbing in that way, because we do think that there's so many things inside of this issue that really do need more attention.
Yeah.
So I want to read you some of the recommendations from the report, and as a doctor, you give me a thumbs up or thumbs down.
Okay. Can we put like Belle Biv DeVoe in the background?
Belle Biv DeVoe. That girl is oh, we should do that. Maybe we'll release it on IG Live and just have all the report authors dancing to Belle Biv DeVoe.
Totally should. Coordinated.
So there are 5 recommendations that come out.
Mm-hmm.
The first is that medications and vaccines that are used to treat the coronavirus or things related to the coronavirus, so comorbidity things, should be offered free of charge.
Mm-hmm.
That's one. The 2 is that agencies within the Department of Health and Human Services should designate systemic racism as a public health emergency.
Mm-hmm.
3 is that we need to take concrete steps towards strengthening the public's ownership and production of medicine.
Mm-hmm.
4 is that we need reparations for the past harms that the pharmaceutical industry has done to folks of color, like we talked about.
Yeah.
And then 5 is using compulsory licensing, which we didn't chat about here, but is, for the folks who are listening, it's basically the government has the right to snatch back from corporations patents that they feel it's in the public's interest to snatch back. So if a drug company is, say, producing a drug that cures a bunch of people and they have the patent and they're abusing the price on it, the government could snatch that patent back.
Like you should be able to free market insulin 50 years later.
That's right. That's right. Yeah. Right. So those are the 5 recommendations. Do those get your approval?
Sure. I think those all sound reasonable.
Great. That's great. Yeah. That's great. Mom would be so upset if you said no, by the way. She would really just embarrass me like that on this IG Live.
She would be very unhappy about it.
Yeah. I'm going to look through and see if there are any other questions. Sean Sebastian changed the lyrics to Belle Biv DeVoe. Never trust Big Pharma and a smile.
Don't trust them.
I'm seeing if there are any other questions for us. So they get invested in by the public but are not required to consider the public as stakeholders in deciding whether the product is made available.
That is correct.
That's absolutely right. So they actually consider their shareholders in deciding whether the thing is being made. Mm-hmm. And I think we talked about this one. Can you talk about the reports of Black people not wanting to participate in trials through the history of? Yeah, we talked about that. Well, we're at the end.
There was a part affecting the effectiveness of the vaccine. This is something that comes up a lot. Is like if you don't have Black people in clinical trials, then aren't you worried about worsening health disparities and things like that? People do. I think there's a yes answer and there's a no answer to that. I think we never reify race equals biology claims. So not having Black people in clinical trials does not mean that you're going to miss some faction of a biological...
Some like genetic thing.
So you're not going to miss that. What you might do in your clinical trial, though, is underrepresent certain comorbidities that because of other structural factors are more likely to be in populations of African Americans. So you might have a less obese or a less... a population with less heart disease or diabetes or combinations of those things. So it's possible, or you might have in your study fewer people who are not able to like social distance or more people. Exactly. So so if your vaccine is relying or your immune response is relying upon a certain level of exposure, your exposures might be very different in a Black population that cannot social distance, that is essential workers, than a population of people who are totally sprawled out in social distancing and,
Yeah.
you know,
Yeah.
and work from home, that kind of thing.
One of the things we talked about in our study was the the connection between stress and other health impacts. So, you know, Black populations, surprise, surprise, are more stressed in their jobs and their
Yeah.
family life and et cetera, because of all these societal factors that we're talking about.
Yeah.
So it seems like that's another thing. Like if you have one population that is
Mm-hmm.
like entirely stressed out in every way and another that is just,
Yeah.
easy breezy as a Sunday morning, then you probably are not studying equal populations.
Yeah, exactly. I mean, there were a couple of publications that basically showed an association between the experience of racism, so
Yeah.
experiencing daily racism, and being more obese or having worse heart disease outcomes and things like that.
Yeah.
And so, I think that there's a possibility that at some level the experience of repeated stressors does alter your biology in some way. That is not to say that like something innate when I was born as a Black person made me more likely to be like overweight and have heart disease. It's to
Right.
say that like living through life and having all of these different societal stressors made me a little bit,
Yeah.
different
Yeah. Yeah.
factors contributed to that. So, I think, and I feel like if studies went into that rather than going down there's some genetic polymorphism that makes people whatever. I think those studies would be much more powerful, right?
Yeah.
There is a disproportionate amount of Black people who die from breast cancer, and there's a disproportionate amount of racism experienced by Black women, and so perhaps
Yeah.
these things are related.
Yeah. 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 Yeah.
Yeah.
Yeah. Well, Lachelle, you've been an excellent guest
Well,
here
this is great.
at
This is
the
wonderful.
Acre IG Live.
I'll accept my honorarium in the form of nickels.
Yeah, right. Honorarium. Honorarium. Yeah, right. Oh, wait, you have another question from Sean. He says that, oh, but we're running out of time.
Oh, this
The,
is
an,
Republicans.
the answer, Sean, is very bad.
Yeah, this is pretty bad.
But we have 15 seconds left. Lachelle, thank you so much. MD, PhD, Lachelle,
Yeah,
from the
everybody
Harvard
social
Hospital
distance, wear
System.
masks, don't
Wear
go to
masks.
crazy pool parties
All right.
indoors.